So let's start with blood pressure, hypertension. There's a clear cutoff value that is used in the clinic, and that's a blood pressure of 140 or more. For systolic blood pressure, diastolic is the lower blood pressure when the heart remains, when the blood is in the heart after the heart pumped into the vessels, so that when the heart is in a relaxing state, then you measure the diastolic blood pressure, and when the heart is pumping, then you measure the systolic blood pressure. So the upper level is 140 as a cutoff value for hypertension, although it's changing now. They are moving to lower targets. For diabetes patients and younger patients, they now use 130 for systolic blood pressure. Do you know your blood pressure? Do you ever measure? Yes? What's your blood pressure?
Mine is really low. I think the highest is like 10 or 9. So I have hypo.
You have hypotension.
Hypertension.
Too
And
low.
I wanted to ask a question about salt when you have hypertension. Because I think I read somewhere that salt also affects the quality of the arteries, not only blood pressure.
Yes, that's good. The question here is, does salt only work through blood pressure, or does it also have other independent effects? And what you say is correct. It does impact also the quality of your blood vessels. Yes, it's a good one. Yes.
Yeah, so for me it's quite low.
Yes, so you take some salt every now and then. Okay, well, it's good also to know that systolic blood pressure, the upper reading of blood pressure, is a more important predictor of cardiovascular disease than the diastolic blood pressure. And that's not always well understood, even not by general practitioners. When they are old school doctors, they think the diastolic blood pressure is the most important, because that's less variable. That's more like a pressure that's always there in your system. And the systolic blood pressure really goes up and down throughout the day, and it's very much affected by stress, by just exercise, by drinking a cup of coffee, and so on. Still, systolic blood pressure is a stronger predictor in our epidemiological studies, and it should not be ignored. You must really measure it at rest because it's so variable, but it's very important. And here you can see from the paper that I put on Brightspace from the European Society of Cardiology, you can see there are different stages of hypertension, 1, 2, and 3, but the stage of hypertension itself does not determine the treatment directly. They always combine it with the presence of other risk factors. And then you have different stages of hypertension, and this is called high normal, but it may be treated when there's also other risk factors like chronic kidney disease. So it's not as black and white as it used to be, that you only have a cutoff for blood pressure and then you treat above that cutoff. Now there's more like taking into account all the other risk factors and making a full picture of a patient with the total expected 10-year risk of getting heart disease, for example. These categories are only important for clinicians. We don't, in research, it doesn't make sense because blood pressure increases the risk of cardiovascular disease gradually. There's no such thing like above 140 you have higher risk and below you have no higher risk of heart disease. So it's a gradual association with the endpoint, and therefore in research we don't do data reduction, making only 2 categories like hypertensive or not. You can see that in papers, but it's mainly to describe the cohort. But when we study blood pressure in relation to outcomes, we try to make use of the total range of blood pressure values in our data set. Okay, so, well, this is quite interesting. This is how to manage blood pressure. This is also in the paper that I put on Brightspace. and there's a kind of total picture of which factors have an impact on blood pressure, how they impact blood pressure, how it all works. Here are the lifestyle factors, here are more like the environmental factors, noise, air pollution, they all have an impact on blood pressure. Of course, how your blood pressure regulation systems work, that's important, all kind of peptides and hormones involved. And there's also some genetics there, and that's mainly polygenetic factors. Sandra Kesten will tell about it later on in the course. There's not a single gene that determines your blood pressure. It's a wide variety of genes that work together to have an impact on blood pressure. Okay. This is quite an important study. It's called the Prospective Studies Collaboration, and there they combined epidemiological cohort studies where they measure blood pressure and the risk of cardiovascular disease. And they pooled all these different studies, and then you get a very large data set, over 1 million of participants with repeated measurements. And what did they find? That for every level of blood pressure, the risk of coronary heart disease mortality goes up for every age range. So there's a strong association, like I said, a graded relationship of blood pressure with coronary heart disease mortality, and an even stronger relation with stroke mortality. So you can see whatever age, whatever blood pressure level, it is associated with cardiac and stroke endpoints. And it's also important that when you see here the cutoff value for hypertension, that below that cutoff value of 140, there is already an association with endpoints. So that's why I say it's only for clinicians that they need guidance when to treat or not. But for us as researchers, we are even more interested in this part of the graph, because most people in society are in this range. So that's for public health and for prevention of disease. This range is most important. Okay. Then I go to the blood lipids. I'm not going to discuss all these cutoff values because you will hear about that later. But I think for now to know is that the LDL cholesterol is the most important part of cholesterol for cardiovascular risk development. There's also triglycerides that are important, or maybe important. The HDL cholesterol was for a long time considered a protective factor because it predicts a lower risk of disease, but the causality of that is now debated. They think that the HDL itself is not a causal protective factor. It is associated with less cardiovascular disease, but it may not be if you intervene on it, if you lower or you bring up the HDL cholesterol by means of medication, for example, it does not prevent that much of cardiovascular events. So the causality of HDL is debated, although it's still an important predictor for less cardiovascular disease, a protective factor, so to say. So, what about cholesterol and prediction of cardiovascular mortality? Well, there's, like for blood pressure, you see these steep associations for all ages. For stroke mortality, it's less clear with the cholesterol. And that can have to do with the mortality outcome for stroke. Because for incident stroke, there's a stronger association with LDL cholesterol. But for stroke mortality in this study, they found neutral associations, which was also at that time quite surprising. So maybe it has to do that there are quite some hemorrhagic strokes in the endpoints, and that's less affected by atherosclerosis than the ischemic strokes. Okay, so this is what I said. The causal role for HDL is doubted, and that has to do also with so-called Mendelian randomization studies. You will hear more about that later. There's also a genetic disease, familial hypercholesterolemia, which is some people have genetically higher cholesterol levels, and that's also quite a risk factor for coronary heart disease mainly. Okay, how is my time? Do you need a break? Is it, or not yet? Almost. Let's see, I only discussed this one because this paper is quite interesting. It gives a nice overview of different foods and all kinds of mechanisms that may be involved when you study these foods in relation to cardiovascular outcomes. So that's quite a lot. There are foods, dietary patterns, nutrients, processing levels, and all kinds of endpoints related to that. And this paper I think is nice for you to read and maybe study in more detail because it's very information dense. And I think, Nea, you will post it on Mindspace today. Yeah? I leave you with this during the break because this is kind of exam type of question. I might ask in the exam for a certain food or dietary pattern or nutrient, describe a mechanism and describe potential endpoints, cardiometabolic endpoints related to that factor. So you can just think over this during the break and see you back then in 10 minutes.
Just a quick announcement for people who are, I can do this later as well, but you're on here, and just as you're leaving, I just wanted to know if for whatever reason you are not going to be part of group work, could you please send me an email? I already have a few people who've done that. This option only exists for people who have done group work last year and are taking this course again for the exam. Those are the only people who can choose to opt out from group work. They can also choose to continue if the topics are of interest. Please let me know in either case. I've heard from a couple of you, but the others who are here only for the exam, let me know if you do or do not want to do